Okay, ladies and gentlemen, thank you for coming to this symposium. My name's Mervyn Morgan. I work for and run the UK and Ireland ITP Support Association, which is based in the lovely county of Bedfordshire, just north of London. I know quite a few of you here, but for those of you I don't know, welcome and thanks for coming. Firstly, I've seen this happen in all of the other talks I've been to so far today. Catherine did it eloquently earlier. There's no fire drill scheduled for this afternoon, so if it goes, just follow me and Catherine out the door. Okay. Basically, welcome to this symposium, which is organised and funded by Novartis Pharmaceuticals UK. I'd like to introduce the panel. Well, first of all, there's the agenda that we're going to go to. Welcome, panel introductions, etc. And the panel is myself, who I've just said who I am. It's also at the far end there, Professor Nichola Cooper, who's the Professor for Immune Haematology at Imperial College London. In between Nikki and Charlotte is Rhona Bowie, who is an ITP patient, who is also Scottish and comes from Aberdeenshire, currently studying at Edinburgh University. Rhona is also a patient observer on the board of the ITP Support Association. And then this end is Dr. Charlotte Bradbury, consultant haematologist at the University Hospital in Bristol. In this symposium, we will cover some of the key aspects of the ITP World Impact Survey, IWish2. Many of you will probably remember about 5, 6, 7 years ago, IWish1, which highlighted lots of useful information covering ITP. ITP 2.0 was the follow-up. This survey saw 1,018 patients and 431 healthcare professionals taking part from 15 countries, which was a really good cross-section of the ITP community. The key results from the survey are as follows. Basically, 54% of patients stated that fatigue was a major symptom of ITP at the time of diagnosis. However, that figure dropped to 48% in the month prior to the completion of this survey. And interestingly, healthcare professionals report an even lower fatigue number for patients at the time of diagnosis of around 26%, which, why there's this difference between what the patient thinks and what the healthcare professional thinks is very, very interesting. 58% of patients highlighted emotional health as an issue during at the time they took the survey. In IWish 2.0, it was 58%. They indicated that they were experiencing mild to severe depression at the time of the survey completion. And so I can only speak from the UK perspective, but as we all know, there is an issue with getting support, etc., for patients due to depression and psychological disorders, particularly when you've just been diagnosed with a disease that to many of them is unknown. But what I would also say is that given the results that we've also had from our own patient surveys at the ITP Support Association, that figure is in line. The next bit, 73% of healthcare professionals considered patient perceptions when making treatment decisions, which is, to be perfectly honest, I know many people would say that's not high enough, but it's a lot higher than it was, and we're particularly pleased with that because at the ITP Support Association, with the support of Nikki and the Charlotte and patients like Rhona, we've been pushing shared decision making as a real tool for healthcare professionals to use and for patients to use. We have various resources on our website that allow patients to actually prepare for their consultation with their clinician. It points them in the direction of which questions to ask, etc. So we're really pleased with that. And then 67%, or 2/3 of patients, showed concern over relapsing if their current treatments were stopped. And funny enough, I was talking to a couple of haematologists earlier in the exhibition where they've had concerns where patients have come to them and said their healthcare trust has actually stopped the treatment that they was having and changed them onto something else when it was working fine. The reasons for that, I don't know. But in addition, 37% or 1/3 were worried about the risk of a watch and wait approach. So there is two different trends there. Now, questions for the panel, and I will go each in turn, and bearing in mind we've only got 30 minutes, so we've got another 24 minutes, ladies. Question 1, the IWISH 2.0 survey tells us that fatigue is a major symptom of ITP, but it is not a routinely assessed symptom by healthcare professionals at diagnosis. Question is, how do we bridge the gap between patients and healthcare professionals' perception on the impact of fatigue? Now, I think I'll go to the patient first because that's what we're all here for. So, Rhona?
That's higher priority, yeah.
I was surprised to see this because fatigue is definitely my biggest symptom of ITP. I was diagnosed a few months after I turned 16 and I'm 22 now, so I've had ITP for around 6 years, and fatigue is without a doubt my most noticeable and my most consistent symptom of ITP. I think a good place to start would be asking why it's not something that's routinely assessed, trying to break this down so we can try and challenge this and change that. Fatigue is definitely a challenging symptom because it can be so hard to explain and also to monitor. You know, you may look fine, but you feel like you're carrying this massive invisible weight that can make everyday tasks so much harder. For example, I definitely experienced a massive sort of disconnect with my body, a feeling that it's letting me down, that I have no autonomy over it like I used to. I'd gone from swimming around 60k a week as a professional swimmer, competing at the weekends, going to the gym multiple times a week, to now struggling to walk up the stairs or to change my bed sheets. And with such a sudden change can come a real sense of grief and loss that you experience. And I think this feeling of grief is only more devastating when healthcare professionals fail to recognise this, focusing only on your platelet numbers and not on your whole well-being, such as fatigue. I used to say to my parents that I wanted them to experience what I was just for a day so that they could truly understand what I was going through and the difficulties that I was facing physically. And I think this same feeling applies in a healthcare capacity. I am going to be dealing with fatigue every day for the rest of my life with ITP, and it would be fantastic to have a healthcare team that not only acknowledges this, but actively aims to monitor it and prioritise this. Because ITP and fatigue especially can be so challenging to monitor, I think that patience from healthcare professionals is the most important thing to start off with. Give the patient the grace to come to terms with ITP and also to understand their limits with fatigue, because it can take years to understand how that works and how that impacts your ITP. And I think this is really the key to bridging that gap between healthcare professionals and patients.
Thank you, Rhona. Nikki, you got any points to raise on that?
I'm not sure I can follow that.
That was superb.
It was
superb.
beautiful. Yeah. And I guess from a clinician's point of view, I think the hard part about fatigue is we don't know what to do with it. And I think that clinicians struggle with that because I don't know how to make your fatigue better.
Yeah.
So I think in a limited time that you have in your clinic room as well,
Mm-hmm.
that sometimes that could be brushed over or that's an exhausting thing to deal with, I think. So how would you recommend we deal, or how do we approach that? Is it helpful for us to say, I understand you have tiredness, but I don't know how to handle that?
Yeah, I mean, I know that, and I'm not walking in, you know, especially now I've had it for 6 years, I'm not expecting kind of a magic solution, as nice as that would be. I think, especially because I was quite young, it was great to be asked, how are you feeling in yourself? And that let me, you know, gather anything that was specifically jumping out to me. Another thing I used to find quite annoying was when my platelet numbers would be better or when my fatigue was maybe less, it was seen as this, fantastic, that's you now. And it was because, say, I've given up swimming, I wasn't doing any other sports, so my platelet numbers were rising and my fatigue was less, but other things in my life were becoming more distant from me. And that ties on to the next question of mental health. So I would say, giving the patient the opportunity to speak about their fatigue and recognizing that it probably will be a lifelong thing that they're going to struggle with ITP, knowing that you potentially can't do anything but they can't either, does create a conversation that you can have maybe more about how to manage it over time. And that's what I mean with give them the grace to discover, you know, I was relapsing when I was still swimming because I wanted to compete, and it took me time to recognize that I couldn't do that. So give them that opportunity, I think, to find that out.
Yeah, I think it definitely helps to have an awareness and recognition, even if we can't fix it, so that they understand that it's a part of the illness, and that it may be the reason they'll struggle to go back to work or need a phase return and may require the sick note or whatever, even when their platelet count is good. I think it's also really important to make sure you've excluded reversible causes, because sometimes there's iron deficiency, particularly with women with heavy periods. Sometimes there's thyroid or even steroid-induced diabetes, and there can occasionally be treatable things. And I do think it needs to be a focus for research trials as a key clinical outcome, because historically there's been so much focus on platelet counts and bleeding, when we know, for example, from the FLIGHT trial, that that's only part of the story, and actually patients may be feeling worse when their platelet count's better. So I think it has to be part of that follow-up conversation of, you know, any bleeding, any bruising, any procedures planned, any side effects of treatment, and how is your fatigue? How are you managing to do what you want to do? And I think just asking about it, even if you can't fix it, is really important. And for things like fatigue, I do think when patients are looked after by specialists that are specifically interested in ITP, that really helps if it's a sort of small team, because there is this familiarity with, you know, the patient journey and the experiences. I think it's much harder when clinicians are looking after just sort of one or two patients with ITP.
Great stuff.
And what things have made it better?
Fatigue.
Anything made it better? Yeah.
I think stress is my biggest thing that decreases my platelets and then impacts my fatigue. Obviously that can be a bit of a cycle of trying to de-stress yourself and then increasing your stress by doing that. I think I found listening to my body is the main thing, which sounds very maybe wishy-washy, but you do...
Be kind to yourself.
Yeah. You become more in tune with yourself and with what you can tolerate and what you can't. And I think that just takes time, honestly. And also, you know, I was 16, 17, 18 when I was going through probably my most severe period of ITP, and you want to be experiencing other things that 18-year-olds are experiencing, and I probably wasn't, and that was difficult, but it also meant that I had to listen to myself and know when to say no to things that maybe I didn't want to, but in the long run, it was better for my ITP.
A lot of people ask me that, does stress cause ITP? And I don't know the answer, but
I certainly don't know the answer to what causes it, but stress certainly does make my ITP more severe.
Okay, thank you. That leads us on to the next question. And if anyone's got any questions, hopefully we will have a couple of minutes right at the end, you know, for Q&As. So question 2, talking about stress and depression, etc. 58% of patients reported mild to severe depression, yet only 16%, that's 116 out of 1,016 patients, were receiving professional support for emotional aspects, and that goes in line with what I was saying about the position in the UK. What can we do to support the mental well-being of patients with ITP? And again, Rhona, I'm going to go to you because you are coming out as the expert on this.
Definitely.
I think, as simple as it sounds, the most important thing to do is to acknowledge that a chronic illness like ITP can impact your mental health. This was something I definitely would have really appreciated, and I didn't receive, especially being diagnosed at a younger age. It can be so alienating and lonely, and this feeling is heightened when healthcare professionals fail to recognise that this might be an impact for you. I think patients can often feel ashamed or embarrassed to be experiencing anxiety or depression after a diagnosis, so simply informing them that this is natural and you might expect this allows us to build that trusting relationship and feel more confident in asking for support in this area. I think signpost mental health services where possible that can be provided to the patient, and although not a mental health service in and of itself, when I discovered the ITP Support Association on my own a few months after diagnosis, this definitely really helped me in feeling less alone, even when I wasn't very active in the community like I am now, knowing as much as it would be great if there are other people out there experiencing something similar to I was, it made me feel a lot less alone in that. I think one of the most essential things to do is to break any stigmas surrounding topics that might be deemed as more taboo or even shameful, such as sexual health or menstruation. It can be difficult to approach these conversations as a young patient. So when I'd gone to the EHA Congress in Madrid and met the other young patient advocates for their own blood diseases, we had all noted that sexual health and mental health were things that were not regularly signposted to us upon diagnosis. And ITP affects every single aspect of your life, and they should all be spoken about and covered equally, I think. So probably to sum it up, acknowledge, signpost, continually assess these symptoms that impact the patient on a holistic level as opposed to just the platelet numbers.
Thank you, Rhona. Charlotte, I'll go to you next.
And I think in many cases we could do better with the initial diagnosis and management, because we often inherit patients that have almost PTSD from that initial night in A&E where you're told you've got leukemia, then you're admitted to hospital and kept in hospital until your platelet count is above a certain level and probably given IVIG because people get bored. And then, and I think if you're seen by the right person early, given appropriate information, and ideally continuity of care really helps. So our specialist nurses are a great kind of contact for patients. So you're seeing the same people each time that get to know you. And obviously it's a luxury, but we're really lucky to have psychological support because there is an acute adjustment to an illness and it's well recognised. And I think, like you say, the kind of recognition. Then my final point is, can I just say steroids usually make things worse? So if you feel bad when you're first diagnosed, you'll probably feel worse after your course of steroids. So just to be warned. Occasionally people feel great, but usually they feel a lot worse.
Okay, Nikki?
Yeah, and I think really important thing to talk about periods. I think very few people do it very well, and the thing I've learned as well about talking about periods is actually really getting down to the basics. How many times you change your pad or tampon, how many times do you end up getting at night? Because I think young people don't necessarily want to talk to you about it. I don't know how you feel about this, but I try to involve the family as well, because so everyone talks about periods. It stops becoming this taboo thing. I've been thinking a while about sort of sexual health that I don't talk about it. I think that I suspect it's something most of us don't talk about actually. One of the things we have done in the adolescent side, so look after children and adults, we've tried to use there's a system, I can't remember what it's called now, which is the HEADS assessment and all of the 12 to 14 and 14 to 16, those assessments I think are really, really critical as well. The other thing I think that happens a lot is because we think that childhood ITP goes away, and I think that we are not good. It's not good to say that. I think it's like say, hopefully it might go away, but it might not actually.
Because otherwise people feel like they failed, or they're a particularly bad case if it hasn't gone away.
And I will say every time you're set up to say it might go away and you get another course of steroids and it doesn't, you feel that double
so I think
almost.
we need to use words better this might become a chronic disease and it's something you will adjust to. But it's that, process. But whereas I think that we also get excited as doctors if things go away too. We need to not be that person, do we? Assuming, whether assuming it's a chronic disease and adjusting to that. This is something.
And somehow helping to cope with the unpredictability and uncertainty, which I think is harder than anything really.
Lovely. Thank you very much. Some great answers there. Right. Question 3. 73% of healthcare professionals considered patient perceptions when making treatment decisions. How can we ensure that patients' voice is considered in every consultation? And this goes on to what we're saying about shared decision making, etc. So, Rhona?
This is a great percentage to see, and I was pleased to see that. I think the main thing from my perspective would be to empower patients with the knowledge of ITP so that they can advocate for themselves going forward in the future. I was lucky that my mum comes from an immunology background, so when I was diagnosed, I was able to ask her questions in more layman terms about my disease, and I had that safe space and environment in which she could explain things to me without me feeling any sense of shame or embarrassment about it. And I think it's this kind of environment that healthcare professionals should strive to create for their patients, one in which they feel free that they can ask questions about mental health, sexual health, how the disease actually functions and what they can expect from their future. I think they have a tendency to forget that we've not studied the same things that they have, and we need things explained in a different way perhaps. It is really emotionally exhausting having to advocate for yourself in everyday life, let alone in this healthcare scenario. So perhaps, like you said, it's good to encourage patients to have family members or a trusted person in the room with them to navigate these conversations. It's obviously incredibly overwhelming to receive a diagnosis, and then to know what to ask for your future and what to expect. So you don't really know what to ask doctors. And so I think this environment means that patients feel like they can circle back round and have conversations maybe about sexual health or periods and menstruation if that changes later on. I think what you guys were saying about creating this patient care perspective is really essential, not simply monitoring the platelet numbers, but also looking at the overall health of the patient. Having these discussions can be incredibly vulnerable. Even me being here today, I'm giving up a certain level of privacy about the mental and physical toll that ITP has on a person. And there feels like there can be this power dynamic between a patient and a healthcare professional in this way. You do end up giving up a lot of your dignity, especially, like you said, being an inpatient, having almost no control of your body or what's happening, and that can be really scary. There's so much shame that I think patients tend to carry around, and it's really difficult to navigate that. For example, standing in a swimsuit, having my parents help me shower in the hospital, having them help me eat, to brush my hair. These were all things at 16 I found incredibly difficult to navigate and to understand. And you have to surrender yourself in this way, and with that comes this real element of trust that you give to your doctors that are looking after you. And with this element of trust becomes a real fear that you won't take us seriously. And I think that that's really the key to considering patients' voices in every consultation. You have to remember that we're not just a platelet number, but we're a person experiencing this life-changing chronic illness, and we're hoping that you take us seriously with that.
Okay, thank you. Charlotte, you want to?
Yeah, I mean, I must say, I'm a bit surprised that it's only 73%, particularly people answering a survey are more likely to say that they do things that they don't. But anyway, we are where we are. But I kind of think it's absolutely critical, the patient's perspective, when you're deciding if to treat or not to treat. And some patients really like the watch and wait approach. Others really keen to be able to continue whatever kickboxing career they want. And then what to treat with is really essential, because obviously there will be occasional patients that want a splenectomy when it's carefully explained. I know that we might think that's not what I would choose, but we have to understand that people have different priorities in their lives. And then when you're considering things like tapering, stopping, again, you need the patient to want to do that, because there is an investment of time and effort to see if they can come off the treatment that's working. And for some patients, they don't want to do that. So, I'd like it to be 100% really.
One day it will be. Nikki, you want anything to add on that?
Yeah, I mean, in some ways I feel like perhaps as doctors we need some re-education.
Yeah.
Actually, and actually some things you said, Rhona, about words and terms, that we're using terminology that makes no sense to you. Yeah. And I think that as we become doctors, we start off with very acute situations where we're looking after people with acute illness, acute leukemias, where they've never seen a doctor before. And that's a very different place to a chronic illness as well. And I think we need re-educating. I think that's not enough. 70% is not enough. So we do need to do more work, clearly.
And the other thing I would say is that there often feels like there's a kind of pressure and urgency to make decisions right now, because I've got my 10-minute clinic slot and I want you to decide that you will have this treatment. Actually, ITP very rarely needs a decision there and then, and you can wait till next week, even if the platelet count's, less than 10, 20 if they're not bleeding. give them a chance to discuss it with their family and things. And I think we need to sort of take away that kind of you must fit in my schedule thing.
They need to take it all on board themselves and then process that.
And I think living with uncertainty as clinicians as well as patients, being able to hold that uncertainty.
Yeah.
That I don't know what your platelet count's going to be in the next few weeks either, or what you're going to respond to.
Yeah.
So, and I think perhaps that's a difficult thing for clinicians to live with.
Okay. Right, moving on now to the fourth question and the final question. We've only got 5 minutes left, or 4.5. Question 4, 67% of patients surveyed reported concerns over relapsing on treatment discontinuation. What support or information can be provided to patients to alleviate concerns with relapse? Rhona?
Take away. I think that this is definitely the hardest and the most loaded question for both all of us to answer, to be honest. I think having panel discussions like this is a really great place to start, so I am really pleased to be here and to be a part of this discussion, especially as a patient. Relapse is probably one of the most challenging aspects of having a chronic condition like ITP. It can feel like an inevitability of sorts, and with that inevitability comes physical pain, discomfort, emotional distress, and I like to call this a fear of the known. Relapse feels like hitting the pause button on my life and like I'm being left behind, and I think that's why so many patients come to fear it and have this real anxiety around it. I don't think that these concerns can ever truly be alleviated, but I think they can be reduced with the right amount of support. So each patient is different. Some may see knowledge as power, whereas others think that ignorance is bliss. I certainly found that it was useful talking through the exact kind of medication, steroids I was on, what to expect when I went off them, what relapsing might look like, so I knew what to look out for. Again, I think this is why it's so important to empower patients with the knowledge of their own disease so that they can understand what they're experiencing. I think this stops what the other fear is, which is a fear of the unknown, one I'm sure many people are familiar with. Doctors can talk patients through what some next steps might be if their current treatment plans aren't working, and this alleviates some of that anxiety surrounding that unknown future of chronic ITP. Ultimately, I think there is nothing that people can do to alleviate all of the anxiety that comes with chronic ITP and relapsing, but acknowledging this and then providing as much information and support as you can to help with these fears to patients after they're diagnosed can alleviate some of these concerns and help patients to feel more in control of their lives and of their disease.
Yep.
Thank you, Rhona. Right. Charlotte, do you want to go
Yeah,
next?
there's a couple of things that definitely can help. So to help the patients accept that relapse may occur, we don't know when and we don't know if, but the likelihood of serious bleeding is really low if it happens. And also if you've previously responded to something like a TPORA, you're very likely to respond again. So it'll be an inconvenience, but potentially not a disaster. And that fear of relapse shouldn't stop you planning, for example, a holiday, getting married, or whatever it is that quite often people put on hold because they're scared about, what if. And I think the other thing is also to have it very clear what to do. So I don't think repeated full blood count monitoring really regularly is the answer. I think making sure there's a really good awareness if you get unusual bruising or bleeding or you need a procedure, this is the number or email to contact. We can get you directly in for a full blood count with the team that knows you. You don't need to go via your GP or whatever. And I think that helps as well.
Okay. Nikki?
Yeah, and I think one thing that I think people get scared they're going to relapse, and actually if you don't have symptoms you haven't relapsed. So just being mindful something terrible is not going to happen to you if you're not having bruising and bleeding. And it's such a straightforward, obvious thing to say, but actually people don't say it. And actually a lot of patients don't realise this, that you're not going to suddenly drop down with an intracranial hemorrhage.
No.
If you've got nothing else, even if you've got bruises, that's not going to happen either. And I think it's something that came out of IWISH as well, as the number of people that thought they might die. And but that's not something we address because we don't think it's ever going to happen. So I think when saying the obvious is really important as well, I think.
It'll never be too obvious for us to hear it.
But we don't.
Thank you very much. Right, we've got about 30 seconds left. We can take one question. There's a gentleman over there. Is there a roving mic somewhere? Yeah.
Go on, jog along. Well done, Jess.
The man with a suit and tie will pass the mic over.
Very well dressed roving mic person.
Thank you.
Thank you. Going back to the fatigue issue, we're seeing lots more awareness of fatigue in other conditions now, post-COVID, etc. And these clinics do have a setup for managing fatigue. Has there been any focus on applying that setup to hematology, looking at how it could be used for our patients, and could we copy any of their practices, basically?
I'll ask the healthcare professionals on that one. Nikki or Charlotte?
Yeah, no, we haven't. I think that we do try to just give
Yeah.
pieces of advice, but I think you're completely right.
Yeah.
We could be borrowing from other groups and things, and actually empowering patients to do that as well, I think is really important.
But I think it is pretty complex and probably heterogeneous, the underlying reasons, and actually there's quite a lot of the depression that feeds into the fatigue, and then, you know, treatment side effects, and then not doing what you love doing, affecting your... so I think actually the individual conversation is really important, and that's why I'm against using sort of a questionnaire fatigue score for general clinical use. I think it's great in a trial when you want to look for changes, but I think that individual discussion is really important. But I agree, there may be ways of coping that we could nick.
I'm conscious now because I'm being told to...
We can. Oh,
One more
allowed.
question.
Jim Bassell.
Dr. Bassell.
Go on.
I was surprised, Rhona, not surprised, but wondering about when you talked about exercise. Because generally I would have thought that doing some exercise would have been helpful. But you said the swimming made you worse. Was it because you were trying to be a competitive swimmer and let's call it overdoing it? Or was it any kind of swimming that would have been too much?
No, I think that's fair to say. I had gone from being a very competitive swimmer, doing British international competitions, and that being kind of my future career path, to then having to try and tamper that down, and I didn't really know how to. You know, I just turned 16. I didn't know how to find that balance of sport, and I think I've been honestly probably kind of scared to go back to it, and worried about a relapse or how that might impact me. And it's difficult to go back to something you love and you're so good at in comparison to doing it now and knowing that my body doesn't really feel the same and can't really do it in the same way. So I would say it's probably more of an issue with my competitiveness than with swimming and the sport itself.
So Rhona, it's exactly like retaking up a hobby when you're middle-aged that you used to do when you were young.
Great stuff.
So you can look forward to that.
I will, thanks.
Okay, thank you very much, panel. Thank you, Nikki, Rhona and Charlotte. Thank you everyone for coming along.